Good afternoon, everyone, and welcome to our webinar on evaluation and diagnosis of patients with hematologic malignancies. So I am Tadel, your host, and I am joined with my co-hosts, Dr. Khalid and Dr. Simon. With us today is Dr. Futsum, co-founder of Yetena Weg and nephrologist at Jefferson University Hospital, and our guest speaker, Professor Ubaldo Martinez. So before we proceed, I would like to say a few introductory remarks about Yetena Weg. So Yetena Weg is registered in Pennsylvania, USA as a non-profit organization that is run entirely by volunteer members. So from a humble beginning of two founders, it has grown to accommodate more than 70 active volunteer members at the moment, spanning across 5 different countries and counting more. So our projects and engagements can be seen in 4 aspects. The first is our health promotion, which works via discussion and articles regarding the health of the general public and health policy and its implementation. One of our other engagements is through blood drive, inclusivity training, equity projects, and fundraising campaigns. Our third project is mentorship and skill sharing, which provides direct mentorship, soft skill training, career and professional development webinars for healthcare professionals. And our last is the CME and research and QI projects, such as this one. So this is a slide showcasing our members volunteering across different events. So Yetenaweg is more than a digital platform. It also provides a place where our volunteers can meet together and volunteer at several activities. So this is another image also showcasing our volunteers in campaign drives, in donations, as you can see from the images. So another of our engagement is through the Yetenaweg Roha Health Article Writing Competition that is done in collaboration with IMSA. So the third round of health article competition was organized in collaboration with the Ethiopian Medical Students Association. Roha Medical Campus through the Roha Health Foundation will award 2 travel article writing competition winners. So Yetenaweg will also award pulse oximeters for the top 20 winners and Littmann stethoscope for the top 3 winners. And the top 5 winners will also get internship opportunities at Roha Health and other partner institutions. So this is a slide showcasing our 2021 and 2022 winners with their respective prizes. So the 2021 is shown on and the 2022 with the prize on the right. This is also another slide showcasing the 2023 winners that got the opportunity to travel abroad to the University of Global Health Equity at the Butaro campus. Another of our projects is the Yetenaweg Roha Research Fellowship. So the Yetenaweg Roha Research Fellowship was done in collaboration with 2 teaching hospitals, the first being the Kurambessa Specialized Hospital that started on March 14th with 3 departments, mainly oncology, radiology, and internal medicine. And research grants were awarded for the top 4 winners and mentorship for the top 10. The other is with St. Paul Hospital Millennium Medical College. So, what makes this unique is it was organized for medical students, mainly the interns. Research grant was awarded for 4 winners. The winners have already been announced. So these are the winners from Tukurambasa Specialized Hospital. So there are 2 residents from internal medicine, 1 resident from oncology and another from radiology. This is another slide showcasing the winners from St. Paul Hospital Millennium Medical College. So these are all interns at the time. So when we come to our CME, this is a slide showing our CMEs throughout the year. So what makes our CME unique is it's freely accessible. Yetenaweg partners with the Ethiopian Medical Association, with the Ethiopian Society of Cardiac Professionals, the Ethiopian Society of Internal Medicine to provide continued training for healthcare professionals. We've had 12 CME webinars so far for the year 2024. So our average webinar attendee ranges from 150 to 200 healthcare professionals. And in 2024 alone, we've planned to have 30 webinars focusing on emergency surgical and medical case, ENT, pediatrics, OBGYN, oncology, and hematology. So we invite renowned local and international speakers. You can access our previous CME sessions via our Yetenaweg YouTube channel that's dedicated solely for this. So you can get updates about our upcoming CMEs by joining Yetenaweg's Telegram channel for healthcare professionals or by following our social media posts. The link will shortly be posted in the chat box. So for the best experience in the webinar, send your questions on the Q&A or the chat box. And at the end of the webinar, your question will be addressed by the guest speaker accordingly. And to get your CU certificates, you must be able to fulfill the following set of criteria. The first is attend the whole session virtually. The minutes attended will be checked by the Zoom attendee reports. The second is to fill the Google form for personally tailored attendance. And the third is to be able to score 50% and above on the post-webinar quiz. So you will be able to see your result right away, but the process of issuing the certificates will take 1 up to 2 weeks to be delivered into your email. So we ask that you wait patiently in the meantime. So thank you. So we are also joined today by Dr. Samuel from the Ethiopian Medical Association. I will say a few introductory remarks about the Ethiopian Medical Association. Please proceed, Dr. Samuel.
Thank you very much, the host, for giving me this chance, and for EMA to give its highlights. I'm Samuel Mangustu, project manager for the Health Workforce Improvement Program. Actually, I have been given this task in a short notice, but it has many problem, and I will try to highlight a few issues about Ethiopian Medical Association. I think most of us know about Ethiopian Medical Association, and it is a membership organization encompassing medical doctors, established in 1962, which makes the first medical or health-related association in the country. And in fact, we are working closely with Yetenaweg with a formal relationship by signing a memorandum of understanding, and we have a long-lasting relationship with Yetenaweg, and we are working hard with this important platform. And EMA major target is in improving medical education and practice. The major visions and missions are crafted in improving the medical education in the country, and as well as medical care, medical practice that's being given in the country through different mechanisms. As I've told you, it is one of the first professional association in Ethiopia with around 4,000 members, actively annual paying members in it. And we do have essential operational sections in our associations to realize our vision and mission, like different projects which are currently being run by EMA. Currently, the major project that's being run by our association is the Health Workforce Improvement Program, in which improving medical education, working closely to avail and to increase access for continuing professional development, and to work closely with the government in regulating the healthcare practices throughout the country. The other is communication and the membership department that we have currently in our association, in which this department works closely with different partners, making EMA visible to the general public as well as general medical practitioners, and attract several members to be actively involved in the association. The other is the IT department, in which the IT issues are being run. And the other thing is the Ethiopian Medical Journal and the research section that we have currently started to give RB for applicants seeking these services. And EMA is currently accredited by Ministry of Health to be an accreditor of CPD provider, as well as to accredit other CPD providers, and as well as to accredit CPD courses. So far, we have more than 40 CPD providers who are currently accredited by our association, and we have developed more than 10 face-to-face courses and more than 10 online courses, and which can be easily available in our website. And I hereby call medical doctors in this platform to be members of EMA if they are not currently part of the EMA membership platform. And also, Ethiopian Medical Association is an active member of the National CPD Committee, in which we are helping the ministry in technical aspects and putting technical guidance for the community at large. And our major platform to work with the government, different partners, stakeholders, and internal members, we have established different standing committees in which we give several technical leadership, and we are crafting annual continuing professional development or CME sessions in it, like Standing Committee of Medical Education, Standing Committee of Continuing Professional Development, Standing Committee of Ethics and Professionalism, and Standing Committee of Medical Research and Professionalism, and Standing Committee of Membership, in fact. So Ethiopian Medical Association, to give a short highlight, I think this is a brief introductory remark about medical association. I hope in the future more clarifications will be given, and we will strongly work with Yetenaweg, and other sessions can be prepared to fully introduce EMA in the larger context. Thank you very much, and I wish you a good webinar. Thank you very much.
Thank you very much, Dr. Samuel. So our guest speaker today is Professor Ubaldo. So I'd like to formally introduce our guest speaker. Professor Ubaldo Martinez received his medical degree from the University of Complutense of Madrid, Spain, then went to Thomas Jefferson University Hospital in Philadelphia to complete his internal medicine residency training and hemato-oncology fellowship. His clinical practice is focused on the care of patients with B-cell malignancies and plasma cell dyskaryosis. He runs clinical trials and is in charge of a laboratory that studies metabolic and microenvironmental drivers of cancer aggressiveness. He has been a faculty member of Thomas Jefferson University Hospital since 2010, serving as an assistant professor, associate professor, and currently as a professor of medical oncology. So in 2020, he was appointed as the co-leader of the Translational and Cellular Oncology Program at Sydney Kimmel Cancer Center. So Professor Ubaldo's research focuses on understanding the role of cancer metabolism at the tumor microenvironment in driving cancer progression and treatment resistance. His laboratory has made important contributions to elucidating the metabolic interplay between cancer cells and stromal cells and how this impacts therapeutic response. He has published extensively in high-impact journals such as Nature Communications, Molecular Cancer Research, and the FEBS letters. Professor Ubaldo is an active researcher and speaker, having delivered numerous invited lectures at cancer centers across the United States. He serves on the editorial board of the American Journal of Pathology and is the section chief of the Cancer Metabolism section of Frontiers in Oncology. He has been a grant reviewer for the NIH and Department of Defense and is a member of several professional societies, including American Society of Clinical Oncology and American Society of Hematology. So with that said, it is an honor to have you with us, Professor Ubaldo. Thank you, and please proceed.
All right. Well, thank you very much for the opportunity to present today. And I'll be talking about the evaluation and diagnosis of patients with hematologic malignancies. So just to start off, obviously, I know there's a wide range of practitioners. All of us are lifelong learners on this webinar. So just to kind of highlight a few kind of introductory remarks, when we think of our classification of hematologic malignancies, we talk about, in broad strokes, about lymphoma versus leukemia. And, we have the legend in the field, Dr. Professor Virchow, who kind of classified this. And obviously, kind of in broad terms, if a blood cancer starts in lymph nodes and causes enlarged lymph nodes, we talk about a lymphoma. If a blood cancer starts in the bloodstream and we see very elevated numbers of abnormal subtypes of cancer blood cells, we talk about leukemia. And historically, our classifications have always been defined on the basis of whether this was a chronic process that occurred over long periods of time versus an acute process. So that's why we talk about chronic myeloid leukemia versus acute myeloid leukemia, chronic lymphocytic leukemia, versus like acute lymphoplastic leukemia. So just to kind of think about these classifications, and obviously thinking about myeloid versus lymphoid malignancies. And right now, and this has been the case for about 40 years, although a lot of the refinements kind of come in this area are based on the cell of origin and the ontogeny, right? What does the cancer cell resemble most? And, this isn't exclusive to lymphomas and to leukemias, to blood cancers, but I think many of the pillars in the field of oncology in general have kind of arisen from these malignancies in this classification. So I'll start off with a case presentation. So this is a patient who presents with a neck mass. He's a 64-year-old male. He has a history of diabetes and tobacco use, and he has non-painful cervical lymphadenopathy of 8 weeks duration. He received a course of Augmentin over a week ago. He completed it, and there's been no improvement. So when we think about the history, what questions would we ask the patient from that perspective? And so I'll tell you some of the questions we asked the patient, since they had cervical lymphadenopathy and we're always worried about possibilities like head and neck squamous cell carcinoma. We wanted to know if he had kind of other symptoms of the head and neck region. So did he have hoarseness, dysphagia, dynaphagia, difficulty swallowing, painful swallowing? And the answer was no, he didn't have any of those. We also, it's relatively common in these patients, also lung cancer. And so we asked about shortness of breath, and he had none. We wanted to know if the patient had pain, and he had none. We wanted to ask about constitutional symptoms, things like fevers, chills, drenching sweats, weight loss, or fatigue, and the patient had none. So again, painful lymphadenopathy, no other major symptoms. So what kind of things do we want to focus on exam? And so, the things that we did focus on was looking at the oropharynx, and we saw that it was clear. The oral mucosa looked fine, but the patient did have poor dentition, and it was obvious on exam that they had cervical lymphadenopathy bilaterally. This patient did not have any axillary or inguinal lymphadenopathy on exam. The heart exam was normal. The lung exam was normal. In the abdominal exam for patients who might have hematologic malignancies, a big area of focus is, does the patient have any hepatomegaly, any enlargement of the liver, any splenomegaly? And the answer was no. Sometimes patients who have inguinal lymphadenopathy, but especially not so much inguinal, but especially retroperitoneal lymphadenopathy, they can have lower extremity edema. This patient had none. We want to look at the neurological exam. They had no focal neurological deficits, and we want to do the dermatological exam and no skin changes. And, some of these, as we're talking about hematologic malignancies, remember that hematologic malignancies are among the malignancies that have the highest rates of paraneoplastic phenomena. So it's not uncommon that patients have signs and symptoms that are not particularly obvious, or thinking about the infiltration of a particular organ and system from that perspective. Okay, so what about tests? What tests would we order? I mean, this talk is about evaluation and diagnosis. So I'll tell you where we started. We got a CBC, a complete blood count and differential, and we looked at the blood smear. And this patient's total white cells were normal. The differential was normal. So the white cell number was 5.7 billion per liter, 63% of the neutrophils, lymphocytes were 32%, and monocytes were 5%. The hemoglobin was 13.8 grams per deciliter, and the platelets were 224 billion per liter. So pretty much, and the peripheral blood smear was unremarkable from that standpoint. And then we got a comprehensive metabolic panel. I'm just showing you here the basic chemistry, with a normal creatinine, a normal potassium. We, for patients with hematologic malignancy, will frequently check a uric acid level because tumor lysis syndrome is not uncommon. And we're always interested in an enzyme called lactate dehydrogenase. So we also look at that. And the LDH was normal, 210 international units per liter. All right. So this patient, ultimately, there was a suspicion that he might have a neoplastic process going on. And so he underwent, ultimately, down the road, a PET-CT. I'm not saying that this has to be done in the early phases, but it's just to highlight that patients with hematologic malignancies frequently have FDG avidity. So obviously this 2-deoxyglucose avidity. And this is just showing you, this coronal imaging showing you the bilateral cervical lymphadenopathy that's highly metabolically active, and the brain is always active. And in fact, that's one of the reasons when we do these PET-CTs, we frequently do them from the base of skull, because they're not particularly good tests, even in the context of lymphomas, which is where this test is done to kind of assess brain involvement. There's always high activity. So just to talk a little bit about staging of lymphomas, the staging here, we talk about stage 1 through 4. In reality, lymphomas are metastatic in nature, always. That's why surgery is a non-curative therapy for lymphomas. But we use staging because it still has important prognostic information, and it kind of guides our treatment. So stage 1 is just one area of disease. Stage 2 is 2 regions. So for example, here would be a patient who has cervical and axillary lymphadenopathy. Stage 3 is multiple regions above and below the diaphragm. And stage 4 is when there's extranodal involvement as well, or more than one site of disease. So here it's just highlighting an example of a patient cervical, axillary, the possibility of hepatic or splenic involvement, the possibility of bone marrow involvement. And so that's why they're all shown in red. And then we talk about B symptoms or constitutional symptoms. And this is very important in the context of lymphoma. So when we're thinking about the evaluation, we want to know, does the patient have fevers, night sweats, weight loss? So what type of biopsy should the patient have if you're concerned about a hematologic malignancy, and especially lymphoma? Should they have fine needle aspiration, a core needle biopsy, or an excisional lymph node biopsy? So the answer is, in general, if the suspicion is high for a hematologic malignancy, the right biopsy is usually excisional. There's a dogma that says the more tissue you obtain, the better. And that's why surgeons and radiologists, they always say, gee, you guys always want more tissue. The answer is yes, because we need to look at the architecture of the tissue. To make a diagnosis of lymphoma, it's very difficult to make it, almost impossible on the basis of FNA alone. And for quiz questions, if there's a statement that says always or never, you have to be cautious about that. But almost never is FNA alone sufficient. And so I can't say never. And we're going to talk about a disease. That's a disease called chronic lymphocytic leukemia, small lymphocytic lymphoma. That disease, in general, in theory, FNA might be sufficient. The same way that disease in particular, if you peripheral blood flow cytometry might be sufficient to make the diagnosis. But that's one of the few exceptions. And obviously, on the basis of tissue, to make the diagnosis, it's very important to have an expert hematopathologist. Okay, so this was the biopsy of this particular patient. These are the results of their excisional lymph node biopsy. And hopefully you can appreciate that basically there are sheets of large round cells. You don't see a follicular pattern from that perspective. And this patient was ultimately diagnosed with diffuse large B-cell lymphoma. His subtype was called germinal center B subtype. The cell stained positive for CD10, cluster of differentiation 10. His cells express BCL6 on the basis of immunohistochemistry, and they lack expression of c-MYC and BCL2. And there is no p53 expression. And then we perform FISH, fluorescent in situ hybridization, and there are no rearrangements of c-MYC, BCL6, or BCL2. And a proliferation marker that was done on the tissue showed 60% proliferation. And we did next generation sequencing, and we found no evidence of a p53 mutation. So A typical evaluation before planning therapy includes history, physical exam, a CBC, chemistry profile, LDH. We always want to look at HIV and hepatitis serologies. Sometimes we will perform a bone marrow biopsy, a PET-CT, an echocardiogram, and that's because patients with aggressive lymphomas will frequently receive anthracyclines, drugs such as doxorubicin, and cardiomyopathy is a contraindication. Congestive heart failure is a contraindication. And we do other tests as needed, such as analysis of the central nervous system via imaging and spinal taps. And, there are particular types of lymphomas, leukemias with very high risk. So all patients with ALL, acute lymphoblastic leukemia, have very high risk of CNS lymphoma, and they need to be assessed, and they need to undergo lumbar punctures with intrathecal treatment. There are some types of lymphomas, such as Burkitt lymphoma, and some cases of diffuse large B-cell lymphoma that have very high risk features. For example, testicular lymphoma in men, breast lymphoma, adrenal gland involvement, renal gland involvement. These are renal involvement. These are all very high risk features. All right. And so when we think about how we classify diffuse large B-cell lymphoma, and I kind of alluded to some of these markers in this patient, we look at CD10 positivity or negativity. And if it's CD10, this is one of the algorithms we use. It's called the Hans algorithm. If it's CD10 positive, we call it a germinal center type. And but if it's not, it could ultimately be something called a non-germinal center type. And so we typically rely on BCL6N1 to classify this. And this has prognostic information, and it might even have therapeutic information, provide therapeutic data. Right now, the thought is that the non-GC subtypes have better outcomes if they receive a drug called polatuzumab, which is an antibody drug conjugate that targets CD79. And we now use polatuzumab for patients with high stage diffuse large B-cell lymphoma. So when we think about the most common lymphomas, this is just showing you classification of lymphomas. It's important to realize that the majority of lymphomas, as far as frequency, are B-cell lymphomas. And the most common lymphoma is actually chronic lymphocytic leukemia, CLL, and that is the most common. But, CLL, chronic lymphocytic leukemia, the majority of individuals the majority of individuals have blood involvement with or without lymph node involvement. And so some of the classifications don't include it. But out of the true lymphomas and non-leukemias, the most common one is diffuse large B-cell lymphoma. And it's here shown as 31%, then follicular lymphoma, and then marginal zone lymphoma. And all three of these, diffuse large B-cell lymphoma, follicular, and marginal zone lymphoma, are all B-cell lymphomas. After that come the T-cell lymphomas, from that perspective. So throughout the world, B-cell lymphomas are much more common than T-cell lymphomas. And I already alluded, our patient, he was diagnosed with diffuse large B-cell lymphoma. And so just so you think about the classifications right now, we talk about GCB, germinal center B-cell-like, non-GCB, ABC, we call that an activated B-cell type. And by the way, this is all kind of has to do with the cell of origin. And then we talk about a group that is non-GCB, unclassifiable. We talk about a group called high-grade B-cell lymphoma that shares some features with Burkitt lymphoma. And then we talk about a group that's called the double expressor subtype. And double expressor means the type that express c-MYC with either BCL2 or BCL6. And just to kind of give you a sense, I already told you at the beginning that hematologic malignancies and cancers in general are a lot of focuses on the cell of origin and the ontogeny. And so, for example, in the context of B-cell lymphomas, we all study in clinical immunology how the germinal center reaction occurs, and centrocytes and centroblasts. And centrocytes are thought to be the cell of origin for follicular lymphoma, while the centroblasts are thought to be the cell of origin for diffuse large B-cell lymphoma and Burkitt lymphoma. And then B cells that have already left the germinal center and that have become activated B cells. That is the cell of origin, or a cell close to a plasmablast for the activated B cell type of diffuse large B-cell lymphoma. And the terminally differentiated B cell, the plasma cell, is the cell of origin of multiple myeloma. And that's associated with immunoglobulin secretion. So not surprisingly, that's one of the tests we use in the context of multiple myeloma. All right. So we use these simple algorithms to kind of better understand, subclassify the type of lymphoma. And, you know, I mentioned to you this Hans algorithm, which is one of the ones that we use based on immunohistochemistry. But the reality is that that is a very crude way of subclassifying it, and that's a reductionist approach to RNA expression profiling that led to these classifications. So this is just showing you how, when you do it on the basis of mRNA expression, there's an important separation thinking about overall survival between GCB and activated B cell type. And activated B cell type has a worse outcome. Our patient has a GCB subtype of diffuse large B cell lymphoma. What about mutations in the context of diffuse large B-cell lymphoma? I mentioned to you that our patient lacked the p53 mutation, but the most common mutations in diffuse large B-cell lymphoma are MLL2, mixed lineage leukemia 2, BCL2, which is fundamental, it's one of the anti-apoptotic proteins, MYD88, which is downstream of the B-cell receptor, and CARD11 also downstream, as well as Notch and EZH2. And CD79B, which is the target of polatuzumab, the drug I mentioned to you before. And, you know, as the field has evolved, we actually don't even really use that classification anymore. For research purposes, we use two genetic classifications of diffuse large B-cell lymphoma. And we talk about subtypes that are classic activated B-cell type, BN2, MCD, other types of G cell, germinal center B cells, and EZH2 B cell subtypes. And, you know, when we talk about this MCD, that's an ABC subtype. Those have mutations in MYD88. That mutation, the one you see there, the L265P, is the most common mutation also, and almost diagnostic, although not quite, for Waldenstrom's macroglobulinemia or lymphoplasmacytic lymphoma, and with CD79B mutation. So again, the subtype is called MCD because of MYD88 mutations, as well as CD79B. Another common subtype, which is the BN2, is its name is derived from the fact that they have BCL2 fusions and Notch2 mutations. The N1 subtype, which is an activated B cell type, is on the basis of Notch1 mutations, and the EZB germinal center beta subtype its name is derived from EZH2 and BCL2 translocations. And this is just showing you some of the data and thinking about the gene expression predictor scores here. And so importantly, you know, these are things we study in medical school, we study in internal medicine residency, we study in fellowship, and sometimes it's hard to see how they would be of clinical importance, but they are important because they allow us to subclassify and think of what is the best way to treat these patients. So very important pathways that have a role in all of this are the PI3 kinase pathway, the B cell receptor dependent activation of NF-kappa B, and I'm showing you there in red CD79B, CARD11 that I told you are frequent mutations, MYD88, and the anti-apoptotic BCL2 family members with BCL2 in the mitochondria. And this is just showing you the importance of how in the modern era, the subtype has a huge impact on the outcome of patients treated with R-CHOP, basically. And we're going to talk about R-CHOP, which is our common therapy. And just when you look at subtypes that are the germinal center subtype, also a huge difference if they have EZH2 mutations. And this is highlighting how there's another classification which is the C0 through C5 classification. This one was developed by Margaret Shipp and her group at Dana-Farber in Boston. And again, on the basis of mutations and gene expression profiling. And once again, showing you that they allow us to better stratify patients and better predict outcome. And again, differences within the groups of the germinal center type and activated B cell type. And we still don't use this commonly in clinical practice, but this is emerging, and you should all be kind of familiar with it, because in the next few years, everyone feels pretty confident that we will be using this in clinical practice. What are some of the clinical factors that predict outcome in diffuse large B-cell lymphoma? Well, importantly, it's things like age, performance status, is the patient fully active or not? Excuse me. I mentioned to you before, lactate dehydrogenase in the blood at diagnosis, the number of extranodal sites if they have more advanced stage disease. And in the context of treatment with rituximab and CHOP, all of these carry prognostic information. And this is called the IPI adverse risk factor classification. And the mnemonic for this is APPLES, right? Age, performance status, lactate, dehydrogenase, extranodal sites, and stage. What are some factors associated with the development of diffuse large B-cell lymphoma? And this is important for all of you, because this is part of your history and thinking about risk factors and the pretest probability of developing lymphoma. So patients with inherited immune deficiency, things like Wiskott-Aldrich syndrome, are at higher risk. HIV infection, patients who've had a solid organ transplant, rheumatoid arthritis, and other autoimmune disorders, Epstein-Barr virus infection. That's obviously very common, over 96% of the population over age 40. Transformation of a small B-cell malignancy in older age are all risk factors. So just to recap, this particular disease, diffuse large B-cell lymphoma, it is the most common non-Hodgkin lymphoma. It's a bit of splitting hairs. You will see this listed. You will see CLL listed. I mentioned that. The peak incidence is in the 6th decade. This is a common feature of hematologic malignancies. They occur in older individuals, except ALL, and Hodgkin lymphoma. Their clinical outcomes and molecular features are highly heterogeneous. These are large cells with loss of follicular architecture, and a significant number of patients present with rapidly enlarging symptomatic mass with or without B symptoms. And they may present as extranodal disease, the stomach, the CNS, the testis, the skin. And in the modern era, over 60% of patients are cured with conventional chemotherapy. And it's important to know that this is a universally lethal disease if left untreated. So patients with diffuse large B-cell lymphoma who do not receive therapy will succumb to their disease, and the median survival is thought to be in weeks to months if not treated. And the typical regimen, the most common way we treat this disease, this isn't a one-size-fits-all, but a substantial proportion of patients receive this, is a regimen called R-CHOP, or CHOP with rituximab. And so just so you're familiar with it, rituximab is an anti-CD20 antibody, and we typically give it, this regimen is given all by infusion bolus, over a 4 to 6 hour period, on 1 day every 21 days. And, most commonly it's given for 6 cycles. So we're talking about 6 times 3, 18 weeks. So after 18 weeks, we hope the majority of patients are cured, and we treat them with rituximab, the alkylating agent cyclophosphamide, the anthracycline doxorubicin, and that's why I told you that we need to get an echocardiogram before starting treatment, the vinca alkaloid vincristine, and the steroid prednisone. A common theme for almost all lymphomas and even ALL of lymphocytes is that they receive steroids. And so here we give steroids, and a lot of clinicians say, wow, are my patients going to become Cushingoid? They typically don't develop Cushing syndrome, because we only give it on days 1 to 5 of these 21-day cycles. We give it 6 times. Obviously, if we kept someone 16 weeks on prednisone 100 every day, that would lead to problems with adrenal insufficiency. But the way we give the steroids, we typically don't see this problem. And why is it that we use CHOP still today? Because more aggressive regimens in the old era did not show a particular benefit. And then, obviously R-CHOP is not always the regimen of choice. Patients with testicular involvement have frequent CNS metastasis, and so we use additional agents. There's a type of DLBCL called primary CNS lymphoma. That's a subtype of diffuse large B-cell lymphoma. R-CHOP does not penetrate the CNS particularly well. So the cornerstone of therapy there is a drug called methotrexate. And then in the skin, we typically are very cautious. Some types do not need R-CHOP, other types need more aggressive regimens. And so, as we're talking about this disease, up until now, I've told you about cancer cell autonomous factors that drive prognosis and that define this disease. But there's a big interest now thinking about tumor-associated macrophages. And it's been shown that higher numbers of tumor-associated macrophages are associated with poor outcomes. And macrophages are divided in an M1 or inflammatory subtype and M2 or reparative phenotype. And it turns out that high numbers of these M2 macrophages are associated with poor outcomes. And so, once we've looked at the patients and we've treated them, in general, we do not, as we're thinking about the evaluation and diagnosis of hematologic malignancies, we typically do not do a lot of surveillance imaging studies. The guidelines say that, for example, a patient with diffuse large B-cell lymphoma should have imaging studies for staging purposes at diagnosis, should receive interim studies after 2 to 3 cycles to make sure they're responding appropriately. I mentioned that the vast majority of patients get 6 cycles, and they should have imaging studies like cross-sectional images such as CT or PET at the end of therapy. And if it's PET, we typically wait at least 6 to 8 weeks because there's a lot of inflammation that can give false positives. And then after that, you don't need any more imaging studies, although frequently, for example, in the United States, we will repeat CAT scans at 6-month intervals for 2 years. And we never initiate salvage therapy if we can avoid it without a biopsy to prove a relapse. Sometimes it could be a different disease. The genetics and the features could change, and that can guide your therapy there. So even though this talk talks about the evaluation and diagnosis, it's important to know kind of what are the outcomes for these patients, for all of us as clinicians. And I realize our group now has a lot of hematologists and oncologists, but the vast majority of patients will be cured with R-CHOP if that's our front line, 50 to 60%. And then the rest of the patients, they can be refractory. That means that the disease never goes into remission. Some patients can achieve something called a partial response, which means shrinkage, but not a complete remission. And 20 to 30% of patients will relapse from that perspective. And so there's a big interest in what are other therapies for this, and I'm gonna talk about that in a minute. But to recap, in some of our diagnostic evaluations, we use molecular genetic testing, we use cytogenetics, FISH, and karyotype, and I already mentioned to you MYC, BCL2 and BCL6, and we do immunophenotyping, immunohistochemistry for MYC, BCL2, we look at CD5, we look at MUM1, Ki67, we look at P53 and others. This is a very condensed slide in that sense. And you're probably all familiar with this, but an exciting development within the last 10 years has been the development, the approval, the standard of care of CAR-T cell therapy. CAR-T stands for chimeric antigen receptor T-cell therapy, and this is now approved for patients with diffuse large B-cell lymphoma in the second line. And basically what this is patients undergo leukapheresis, so the white cells are taken out. The T-cells are engineered to express this CAR product, and we're going to talk about it. It's in panel B here. And then they are expanded and they are reinfused into the patient. The CAR-Ts that are approved right now are targeting anti-CD19. And so this construct that is introduced into the T cells via a lentivirus includes an extracellular domain, which has an anti-CD19 antibody variable domain. It has a transmembrane domain, and then it has co-stimulatory domains as well as TCR, T cell receptor signaling domains. So the classic ones are, it includes this anti-CD19 antibody. The clone is called FMC63. The transmembrane domain is that of CD28, which activates T cells, and then the T cell receptor signaling domain includes CD3, and it includes things like 4BB1. And what this ultimately leads to is cures, even in this relapse refractory setting, in over 40% of patients in that context. So it's really been a revolutionary therapy. It's taking the patient's own T cells, reprogramming them in the lab, and reinfusing them into the patient and curing these patients. The costs are astronomical. So in the United States, for example, the cost of CAR T is over $500,000 per patient. And so obviously, the field is still grappling on how to kind of deploy this and make sure we do it in the most efficient manner. So there are highly proliferative variants of diffuse large B-cell lymphoma, and we talked about this double hit. There's a type that looks MYC positive, DLBCL, or diffuse large B-cell lymphoma with a proliferation rate as measured by Ki-67 of greater than 90%. And so, when we think of this a little bit, we have the germinal center subtype, the activated B cell type, and we talked about subclassifications. So just to kind of highlight a little bit when we're thinking about the evaluation and diagnosis of hematologic malignancy, and I started with diffuse large B-cell lymphoma, either the most common or the second most common type of lymphoma. It is the most common, without a doubt, aggressive non-Hodgkin lymphoma, and several biomarkers are available to delineate prognostic groups, and we talked about the clinical features, immunohistochemistry, gene expression profiling, and FISH. All right, moving on to a different type of lymphoma. This one's called Hodgkin lymphoma. And just a vignette, this is a patient who presents with chest pain. He's a 41-year-old, so he's a bit younger. He has a history of a low-grade prostate cancer. He developed severe chest pain after ingesting alcohol. This is a very classic history, although extremely rare. And he was found to have a mediastinal mass, and a biopsy of this mass was diagnostic of nodular sclerosis, Hodgkin lymphoma. Hodgkin lymphoma was described by Dr. Hodgkin in London. And, his life is fascinating. If you're ever interested, you should read up on it. And he was persecuted because he was a Quaker, actually. And, when he described the disease, he described these young children or these young adults who had had painless lymphadenopathy, very bulky, for many years before diagnosis. So when we think about the clinical features, lymphadenopathy with an enlarged painless lymph node, they're above the diaphragm in over 90% of cases, and hepatosplenomegaly is pretty rare, and B symptoms are very common, and so it's very important to think about this. Fevers, night sweats, and our definition of weight loss is greater than 10% within 6 months. And when we think about the epidemiology and diagnosis, thinking about pretest probabilities, the majority of lymphomas and leukemias occur in elderly adults, but Hodgkin lymphoma has a bimodal distribution, and the first peak is in young adults between the ages of 20 and 24, and the second is in the 6th decade. And this disease is diagnosed by the presence of a minor cellular component, the Reed-Sternberg cell, found in the appropriate cellular background. And so this is just showing you an example. The very large cells here, the ones that are binucleated, are the Reed-Sternberg cells. The very large cells that are mononucleated are the Hodgkin cells. And what I'm highlighting here is that the vast majority of all these small cells that you see are non-cancer cells. And on average in Hodgkin lymphoma, less than 1% of the cells will be cancer cells. And we classify it on the basis of nodular sclerosis, which is the most common, mixed cellularity, lymphocyte deplete, lymphocyte rich, and nodular LP Hodgkins. In reality, nodular LP Hodgkins, for historical purposes, it's called Hodgkin's lymphoma, but it's a classic B cell lymphoma. And very classic markers on histology are CD30 and the Golgi of these Hodgkin-Reed-Sternberg cells, and CD3 in the reactive T cells in that context. And the majority of patients with Hodgkin's have stage 1 or 2 disease. It's rare to have stage 3 or 4. But this is a good reminder of the classification and staging of lymphomas. Stage 3 with disease above and below the diaphragm, and stage 4 with multiple sites of disease, or at least more than one site of disease, and with extranodal involvement from that perspective. And so our patient, he underwent a PET scan. This is highly unusual. This example here, because we're showing you axillary and pelvic sidewall, iliac involvement. The majority of patients with Hodgkin's have contiguous lymph node involvement. So the classic scenario is you have cervical, supraclavicular, and mediastinal. But it's very rare to, for example, have cervical and abdominal lymphadenopathy without mediastinal. Contiguous is one of the key features. And then when we think about what are unfavorable characteristics, well, if it's mediastinal in origin, if it's a large, if it's a bulky mass, age, the fact that if the patient has extranodal disease, if they have high inflammatory markers such as the SED rate, the erythrocyte sedimentation rate, if they have B symptoms, and the number of nodal areas involved. And so we also use, I told you about the IPI in the context of diffuse large B-cell lymphoma, and we use the we use the International Prognostic Score and Index, IPS, and it's defined by age, male gender, stage, the albumin, the hemoglobin level, the leukocytosis, and the lymphopenia. So again, in hematologic malignancies, we frequently check things like the albumin level. I mentioned in diffuse large B-cell lymphoma, the LDH. We check it in Hodgkin's too, the erythrocyte sedimentation rate in the context of Hodgkin, and we even use the total white count and the lymphocyte, the absolute lymphocyte count, in order to prognosticate in the context of Hodgkin's. And our patient was diagnosed with stage 3 disease, and they ultimately received a treatment called ABVD, and they were cured. And so next, I'm going to tell you briefly, kind of embedded in this, my own research, kind of in part in this field. And so what we've been studying is how do tumors thrive in nutrient-poor conditions. And, we've taken inspiration in some of the work on coral reefs and how they thrive in nutrient-poor waters. And so my lab has been working on this concept that non-cancer cells might support cancer cells metabolically. And so over many years, we've studied transporters of metabolites such as MCT4 and MCT1, which are involved in the release and the uptake of lactate. By the way, lactate dehydrogenase is the terminal enzyme in lactate production, the conversion of pyruvate into lactate. And we've also been studying markers such as TOM20, transporter of the outer mitochondrial membrane, which are markers of mitochondrial metabolism. And this is just showing you, for example, in the context of diffuse large B-cell lymphoma, this lactate exporter, how if you look at a reactive lymph node, there's no expression, but when you study cases of diffuse large B-cell lymphoma, you see it. But I already told you diffuse large B-cell lymphoma, and I gave you examples of the histology. It's typically large round cells. And you can probably already appreciate that the brown staining that you see is filamentous in nature. The cells look spindle-like. So it turns out these are not the cancer cells. And so we did double labeling by immunofluorescence. And we did it with CD68, which is a marker of macrophages and monocytes. And what we found is that the MCT4 is highly expressed in the macrophage, not the cancer cells. And then we looked at the importer of lactate, and this is shown in red on the right-hand side. And we found that the importer is highly expressed in the cancer cells. We compared reactive lymph nodes, in the germinal centers. There's where you see a little bit of brown on the left compared to diffuse large B-cell lymphoma, and there's a very strong upregulation of MCT1. And what we ultimately found in diffuse large B-cell lymphoma, also with these other markers such as Tiger, is that they're highly expressed. And when we look at PD-L1, which is part of the immune checkpoint blockade, we find that it's highly expressed in these same macrophages. And we went on to study this in Hodgkin's lymphoma, and we saw a similar pattern with markers of mitochondrial metabolism in the cancer cells, markers of lactate uptake in the cancer cells, and markers of lactate release from non-cancer cells. That's what's shown here, and what's shown by double labeling and by immunofluorescence. But importantly, what this shows is this is associated with outcomes. So, for example, the patients with Hodgkin lymphoma that have very high expression of TOM20, this marker of mitochondrial metabolism in the cancer cells, and high expression of MCT1 in the cancer cells, but high expression of MCT4 in the stroma, almost 100% of these patients relapse. While as the other patients, the ones that lack this pattern of metabolic compartmentalization, they fare fairly well. 80% of them are cured with frontline therapy. So how do coral reefs thrive in nutrient-poor waters? The answer is the metabolic symbiosis between algae, sponges, and the coral. And we believe that similar phenomena are occurring in these lymphomas. And we're doing clinical trials right now to see if we can intercept this and improve outcomes. In the context of Hodgkin lymphoma, how we treat it is with a regimen called ABVD. And I'm just showing you this regimen because when you're thinking about the evaluation and diagnosis, it's important to kind of be familiar with the drugs so that even if you're an internist or another kind of doctor, you have a good sense of why we do pre-treatment testing. So again, we get an echo because of the use of doxorubicin. ABVD includes bleomycin, so we do PFTs there, then blastin, which can cause neuropathy down the road, and carbazine, which puts patients at risk for myelodysplastic syndrome. And one revolution in the context of Hodgkin's is this is one of the diseases where patients receive immune checkpoint blockade, and the data with nivolumab is very positive. It worked well in nivolumab and pembrolizumab. These are these PD-1 inhibitory antibodies. And we're now, in the context of Hodgkin's, trying to de-escalate therapy. So do as little therapy as possible because the vast majority of patients are cured. And this is the RAPID trial, and showing that we could avoid radiation therapy in these patients. And there's another landmark trial called the RAFL trial, where instead of giving ABVD, we were able to just give AVD in this context. And I just want to highlight that the vast majority of patients are cured with Hodgkin's lymphoma. So it's estimated that only about 12 to 15% of patients will relapse, and the majority of relapse actually we diagnose them on the basis of clinical presentation. So we don't rely a lot on imaging studies to monitor for relapse. A bit like diffuse large B-cell lymphoma, we say you can get CAT scans every 6 months for 2 years if needed, but we don't put a lot of emphasis on that because the vast majority of patients will relapse by symptoms. So, and this, remember, for all of us who are clinicians, doctors taking care of patients, this is really empowering. Still, in this day and age, it means that obtaining a history, performing a physical exam, getting basic labs are probably the most powerful tests in order to diagnose relapse of lymphoma. So all of us internists, family medicine doctors, you're at the forefront of surveillance and evaluation of lymphomas. What about late complications of therapy? So patients treated for Hodgkin's lymphoma are especially those that get mediastinal radiation are at very high risk of dying from cardiovascular disease, from second malignancies. So the graph is just showing you that the risk of relapse, goes down dramatically after 5 years, but the the risk of other cancers and cardiovascular disease continues to rise. And this is very important because when you think of when you see a patient many years after their diagnosis, if they're having a symptom, for example, say they're having a symptom that you think could be cardiac in nature or could be related to relapse of Hodgkin's in the chest area, for example, the more likely scenario is that it's not related to Hodgkin, but it's more a complication of treatment, such as valvular heart disease, such as cardiomyopathy, constrictive pericarditis, aortic valve disorders because of the radiation to the valve. So when you think of the late toxicity of treatment, the secondary malignancies are a big concern, and it's things like AML. Their relative risk is 70 times that of the general population, and other solid tumors. And for example, women who've received mediastinal radiation because of the breast involvement with the radiation, they're at a higher risk, and we have to do surveillance for that. And, you know, when you think of the late toxicity of treatment, things like cardiac disease with coronary artery disease, MIs, cardiac arrest, pericarditis, valvular abnormalities, I mentioned before, are very important. And, you know, obviously we worry a lot about problems with infertility. These are young adults, so it's definitely a big challenge there. And when we think of those risk factors for cardiac disease, we worry about the mediastinal radiotherapy doses, the fact that they receive doxorubicin, you know, anthracycline-based chemotherapy, if they receive radiation at a younger age, or if they have hypertension. And I'm not going to go over this in great detail. Hodgkin's is a disease of a crippled B cells, and we think, again, NF-kappa B activation is very important, and the Epstein-Barr virus. And we think that the cells, the non-cancer cells, are absolutely critical. In fact, they're the vast majority of cells in the tumor. And right now, the therapy that works best in the relapse refractory setting, which is PD-1 inhibitors, you know, nivolumab, pembrolizumab, these drugs are targeting the CD8 T cells and the CD4 T cells. So just to recap the pathophysiology so we can better understand the evaluation and diagnosis of Hodgkin's, the Hodgkin and Reed-Sternberg cells are the classic cells, but again, they are B cells, but they lack expression of many B cell markers such as CD20. These cells have important activation of NF-kappa B, and they attract many other cells to the lymphoma tissue. So in summary, it's an indolent lymphoma, but highly curable. The diagnosis is based, once again, on pathology, and the staging studies are absolutely critical. And we have to examine patients and perform imaging studies. And the treatment, we didn't go over it in detail, but chemotherapy, radiation, sometimes we use transplant. We use this regimen called ABVD or AVD, and it's been quite a revolution. And in the context of relapse, the most important thing is the clinical evaluation. And I want all of you to think a lot about the possibility of late complications such as cardiac cancer complications, infertility, and hypothyroidism. Moving on to a disease called multiple myeloma. It's another hematologic malignancy. It's of the terminally differentiated B cell, but this time it really has very little similarities with lymphoma. And it's another disease where really more than the multiple myeloma cell, a lot of the problems the patients face are related to the non-cancer cells in its environment, especially the osteoclast, which weakens the bone. And we know that 100% of patients with multiple myeloma will have a preceding monoclonal gammopathy of undetermined significance, whether we diagnose it or not. And the important clinical features is that there's bone marrow failure. Patients typically present with anemia. There's renal failure. There's bone disease with skeletal destruction, lytic lesions, and there's hypercalcemia. And there can be additional features because of hyperviscosity, recurrent infections, and amyloidosis. And in this disease, we perform always a bone marrow biopsy and aspirate. We perform a serum protein electrophoresis and immunofixation, and other tests, including imaging tests on the basis of this. And the serum protein electrophoresis is basically taking serum, running it on the basis of a charge and looking to see if in the gamma region, which is where the antibodies are, there's an abnormal spike. And so these are showing you kind of the examples where you could see in the gamma region in the bottom, the top is normal, but in the bottom ones, whether it was a case of MGUS, smoldering myeloma, or multiple myeloma, you can see that M spike. And this is just showing you the importance of X-rays. This patient has lytic bone lesions in the skull. That's why we get skull X-rays. Those don't require any therapy per se towards the skull. They don't require radiation to the skull. And on the right-hand side, it's a humeral fracture from that perspective. And we frequently do PET scans to understand the extent of disease. And we especially use it to try to determine if somebody has smoldering multiple myeloma or active multiple myeloma. And this is just showing you the frequency of different clinical and laboratory abnormalities. So anemia is the most common, along with bone lesions, and renal failure is less common, but it's devastating. It's usually the worst prognostic indicator. And then hypercalcemia from that perspective. And the most common type of renal dysfunction in the context of multiple myeloma is cast nephropathy, which occurs in the tubule, but there are many possible causes of renal failure in the context of multiple myeloma. And this is just showing you some of them, including tubulointerstitial nephritis, amyloidosis, light chain deposition disease, immunoglobulin deposition disease, other issues related to hypercalcemia or uric acid. And I'm not going to go over the definitions of all of this, but I mentioned to you that every patient with multiple myeloma had preceding MGUS or smoldering multiple myeloma. And obviously those with smoldering multiple myeloma at diagnosis are at much higher risk of developing multiple myeloma than those with MGUS. And we see people who have a long history of MGUS before they're diagnosed with multiple myeloma, and we see other patients that immediately they evolve into multiple myeloma. And in the context of this disease, some patients can have it just a plasma cell neoplasm in one site and nowhere else. And we don't call that multiple myeloma. We call it a solitary plasmacytoma. And those can be treated with radiation and cured. Not cured, but sometimes it doesn't relapse for many years. And, you know, if it doesn't relapse in 50, 20 years and you were diagnosed in your 70s or 80s, you might live your whole life without any problems from that. And these diseases, again, you know, one of the features that they have is lymphomas, multiple myeloma, leukemias. They can cause problems because of the local effects, right? You have a tumor of these cells that causes problems, but they can also cause problems because of paraneoplastic phenomena. And paraneoplastic means the soluble substances. So, for example, a very classic one is they can cause amyloid deposition, or it can be antibody mediated. And antibody mediated could be things like immune thrombocytopenia, autoimmune hemolytic anemia, paraneoplastic neuropathy, CNS involvement. These are all fairly common. And amyloidosis occurs in about 10% of patients with multiple myeloma. And this is this particular type of deposition of the protein with these beta sheets. But there are many types of amyloid. AL or light chain amyloid is the one we focus on in hematologic malignancies. But there's transthyretin, which can cause cardiomyopathy. ApoA1 in the context of kidney disease, and many others. And typically, as you know, it's diagnosed with Congo red staining and apple green birefringence, and that's shown in the bottom right panel. And this is just showing you the types of amyloidosis. We focus on light chain amyloidosis. It's the most common type that causes clinically relevant disease, and it's due to kappa or lambda light chains. And you have to prove that the amyloid, it's not sufficient to just stain for Congo red and show amyloid deposition. You have to prove that it's the light chains. And right now in the United States, the test of choice is mass spec to prove that the protein sequence is that of the light chain of immunoglobulin. And this is showing you some of the clinical manifestations. They're all different, but just to kind of suffice to say that AL, the one that's associated with a plasma cell neoplasm, is typically has kidney and heart involvement, and others are more rare. But among the ones that have heart involvement, for example, TTR, either wild type or mutated TTR is the most common one that has heart involvement. And it's absolutely essential to know the type to treat it accordingly. So when we think about the natural history of plasma cell dyscrasias, and from MGUS, you can evolve to active multiple myeloma, or you could evolve to light chain deposition disease, amyloid, and so forth. And these are diseases that are hard to diagnose because they rely more on laboratory testing and tissue sampling than they do on suspicious imaging findings from that perspective. So hopefully I've told you a little bit about the workup of multiple myeloma and how to distinguish active multiple myeloma from smoldering and MGUS. And these two diseases, smoldering and MGUS, the definition is there cannot be any end organ damage. So moving on to MDS and MPNs, so myelodysplastic syndromes and myeloproliferative neoplasms. Just to give you an outline on these, within the myeloproliferative neoplasms, we talk about CML, P. Vera, ET, and primary myelofibrosis. And just to kind of think about the subtypes of these, they are all in a spectrum. And that also includes a disease called chronic myelomonocytic leukemia and acute myeloid leukemia. And we think especially in the elderly, a lot of the cases of acute myeloid leukemia will derive from MDS. And especially AML is another disease that can be diagnosed on the basis of the peripheral blood evaluation and flow cytometry. So really CLL, AML, even although that's a bit more controversial, MDS can be diagnosed on the basis of peripheral blood assessments. But typically for myeloid malignancies, especially the acute types, AML and MDS, we typically want to perform a bone marrow biopsy. So MDS is, the definition is a clonal hematopoietic stem cell disorder characterized by ineffective blood cell production, dysplastic morphology, classic genetic features, and variable risk of transformation to acute leukemia. And we've all studied this, the ontogeny of myeloid blood cells, and the dysfunction can occur at almost any step. But the important thing is that it typically occurs in elderly individuals, and it can be associated with previous chemotherapy or radiation. And there are genetic syndromes that are associated with this. And it's very important to think about the peripheral blood and the bone marrow. And in the peripheral blood, we're always interested to evaluate the anemia. We're obviously interested in understanding if there are dysplastic features, especially in the leukocytes typically. And in the bone marrow, we want to see if it's hypercellular, excuse me, and if there's morphologic dysplasia. So this is just showing you some examples, the hypolobulated neutrophils with the arrow here on the right-hand side. That's called the pseudo-Pelger-Hewitt abnormality. And you have for reference below a normal neutrophil. And then we look at dysplastic erythrocytes in the bone marrow space. And we look at ring sideroblasts. That's when we do stains for iron deposition, and that's occurring in the mitochondria. And again, another feature of this. And we look at the megakaryocytes in the bone marrow space. And, these are multinucleated cells. And when there's separation for micro megakaryocytes, those are concerning features. And obviously, the symptoms can be related to the lineage and severity of the cytopenias, such as fatigue, exercise intolerance, easy bruising. And the treatment is typically supportive with transfusions. And right now we have, for MDS, we typically use hypomethylating agents. We're using a drug called venetoclax, which is a BCL2 inhibitor. And, bone marrow transplantation is the only curative therapy. But obviously, it's challenging in older individuals to take them to bone marrow transplant. And we use the genetics and the karyotype in order to define the subgroups. And we use the number of blasts to define it. And then when we think of myeloproliferative neoplasms, again, they are hematopoietic disorders, but here they're characterized more, instead of ineffective erythropoiesis and ineffective hematopoiesis, they're characterized by proliferation. And so again, now we know the vast majority of them are driven by kind of two phenomena. One is the Abelson kinase in chronic myeloid leukemia, and the other is the JAK-STAT TPO pathway in essential thrombocytosis and polycythemia vera. And so these are, again, genetic abnormalities in the stem cells, and we are very interested in doing genetic studies to see if there's a BCR-ABL fusion, or if there's a JAK2 mutation, or if there's a calreticulin mutation. They're not very common, but they've kind of led to a lot of paradigms in the context of oncology. So we look at CML being BCR-ABL positive, and we look at Vera and ET, the vast majority of them being JAK2 positive. And CML is defined by something called the Philadelphia chromosome. It's called the Philadelphia chromosome because it was described here in Philadelphia, and it's the translocation that leads to the Abelson kinase being activated by the BCR region. And in the vast majority of patients, they're diagnosed in chronic phase, and this has a duration of 4 to 6 years if left untreated. But today we use tyrosine kinase inhibitors, and the overall outcomes are excellent in chronic phase. The blood basically shows a wide spectrum of maturation. You typically see predominantly neutrophils. You see basophils in the blood, and you can see metamyelocytes, myelocytes, promyelocytes in the blood. And if a bone marrow biopsy is performed in chronic phase, you will see a hypercellular marrow with granulocytic predominance, and you'll see the full range of myeloid maturation. And we typically talk about hypo-low beta megakaryocytes, or these dwarf megakaryocytes, and importantly, less than 5% blast. So you can see this is a packed marrow. Imagine, we typically say the cellularity should be 100 minus the age. So imagine if this is a 60-year-old, you would expect 60% fat. You see kind of complete effacement. And here you're seeing a lot of megakaryocytes, a lot of myeloid precursors. And in blast crisis, you see the number of blasts increase. And when patients have progressed, you typically see a rising white count, and you can see more problems related to cytopenias of the normal cells, such as infections and hemorrhage. But the vast majority of patients with CML are diagnosed when they're asymptomatic, and it's not uncommon for myeloproliferative disorders that they have splenomegaly from that perspective. And the drug we used to use all the time was imatinib from that perspective. And again, I mentioned to you before that really all myeloproliferative disorders kind of ultimately are driven by JAK-STAT signaling. So this is important from that perspective. This is how drugs like imatinib and all the BTK and all the tyrosine kinase inhibitors work. They bind to the enzymatic pocket in the Abelson kinase, and therefore don't allow the downstream effects of the Abelson kinase, which is to phosphorylate tyrosines such as crackle, and that leads to the development of CML. In P. Vera, the typical feature is, obviously the defining feature is that patients have polycythemia, very high red cell mass, and this is independent of erythropoietin. So if you check an EPO level, it's low, and patients have a mutation in JAK2 from that perspective. And as I mentioned to you before, over 90% of patients have mutations in JAK2, and then this leads to downstream activation of the JAK-STAT pathway. So some of the major criteria are having a very high hemoglobin level, having an elevated red cell mass, and obviously very important to have the JAK2 mutation. And so this can be tested in the peripheral blood. Not all cases of polycythemia vera have JAK2 mutations, but over 95% of them have it. So this is, once again, one of these diagnoses that can be made on the peripheral blood. If patients undergo a bone marrow biopsy, you're going to see panmyelosis. you're going to see a very hypercellular marrow with full maturation and a mild increase in reticulin fibers. And how do patients present with this? Well, many times they'll present with splenomegaly. They'll have a ruddy color of their face. They'll have hepatomegaly and high blood pressure, and they're at higher risk of GI bleeding or things like Budd-Chiari. So it's not uncommon that they could have mesenteric or hepatic artery thrombosis, and they can have things like headache, weakness, pruritus. The reality is, in this day and age, a lot of patients with myeloproliferative disorders or neoplasms are being diagnosed incidentally on the basis of blood work, right? They have a high red cell count, hemoglobin, they have a high white count with the differential showing myeloid cell, or they have very high platelets in the context of ET. And the typical treatment is phlebotomy, aspirin, and down the road they're getting JAK2 inhibitors. And in ET, it's a sustained elevated platelet count. And if patients undergo, they also have JAK2 mutations or calreticulin mutations in almost all cases. And if you marrow these patients, they have increased megakaryocytic hyperplasia, and they typically don't have iron deficiency, because iron deficiency is obviously a cause of thrombocytosis. And primary myelofibrosis is also activated by this pathway. And these patients typically do have massive hepatosplenomegaly. And in the blood, you even see a myelophthisic picture with nucleated red cells and myelocytes, and with a lot of fibrosis in the bone marrow. And this is just showing you kind of the common mutations that we see and the common driver mutations in these diseases. So we see JAK2 mutations, calreticulin, MPL, and CSF3R as CSF3R, though, for chronic neutrophilic leukemia from that perspective. So just to give you a kind of framework for the diagnostic workup of myeloproliferative neoplasms, we test for JAK2, and we test for things like BCR-ABL, calreticulin, and MPL, but we typically start with JAK2 V61F mutation testing. So when you think, we have more modern classifications than the 2008, but I think this is a good framework to think about these diseases. We think about myeloid neoplasms as AML, MDS, MPNs, and then overlap syndromes. And, all of them can evolve into AML. And so with this, I'll stop. I'm sorry it's been kind of a long presentation, but hopefully you've got a sense that detailed history and physical examination are essential. And, this helps us, and we have to be aware of the pretest probability, right? This is absolutely essential. And, hematologic malignancies usually require tissue diagnosis. And we talked about some exceptions such as CLL, CML, P. Vera, ET. We talked about the importance of ontogeny, the importance of genetic testing. And for example, we talked about the value of PET-CT in the context of lymphomas. And, just to recap, imagine, if for you as a clinician, you should think that many times, even detailed analysis of the blood might not give us the full picture of the diagnosis. That's where hematologists and oncologists come into play. But in a disease like CLL, that's sufficient with peripheral blood flow cytometry. Thinking about the pretest probability, for example, as an example, if you have a patient with Hodgkins who many years after the diagnosis now is having some kind of symptoms such as dyspnea, chest pain, there's a higher likelihood that it's not the Hodgkins lymphoma, but that it's a different disease. Thinking about the pretest probability, if you see an elderly individual with pancytopenia, a very common scenario is that they have MDS. So I think all of this just helps you kind of frame thinking about pretest probability and hematologic malignancies. And I'll stop here, and I am happy to take any questions. Thank you.
Thank you very much, Professor Ubaldo. That was a very interesting and immersing presentation. So you've provided us with a comprehensive overview of the latest diagnostic techniques, the risk stratification methods, and guidelines for the management of various hematologic malignancies. And the case studies you shared helped illustrate these concepts in a pragmatic and relatable manner. So once again, thank you. So having said that, we'll directly proceed with the Q&A. My co-host, Dr. Samon, will share his screen. A few questions have been asked in the chat box as well as on the Q&A. So my co-host will read them to you. We'll go back and forth. And after that, we'll proceed with the quiz. Thank you.
All right, Dr. Ubaldo, can you hear me?
Yes, very well.
All right, so the first question we have says, what are the feared complications of CAR therapy?
Yeah, no, it's a very important question. So the most feared complications of the most feared complication of CAR T, of chimeric antigen receptor T cell therapy, is the concern for neurotoxicity and also for something called cytokine release syndrome. So these therapies lead to massive cytolytic granule release, and it's thought that this occurs in the brain as well. And patients, for example, in the brain, when these cells are activated in the brain, the spectrum of problems can start off with just mild confusion all the way to seizures, massive cerebral edema, and death. And that's a reason why actually patients who receive CAR T for at least the 30 days post-therapy, they require to live close to the hospital, and they require so that they can get immediate therapy. And these complications typically are treated, if it's the neurotoxicity is typically treated with high dose steroids and anti-epileptic drugs and things like that. But if it's the cytokine release syndrome, also typically we use these anti-IL-6 drugs such as tocilizumab. So that is one of the very common and feared complications of CAR T. And so it requires a caregiver at any given time with the patient, and it requires to be in close proximity to the hospital. So for example, for us in Philadelphia, patients who live hours away in more rural areas, they have to stay in the Philadelphia area for the 30 days for this, from that perspective. By the way, I see in the chat, and we'll go over the other questions. I see that somebody had astutely pointed out that the phlebotomy recommendations for P. Vera have changed, and that is absolutely correct. And those slides were just put, as a prop to kind of discuss our management of it, but it wasn't intended to be really the specifics of how we phlebotomize patients. So thank you for pointing it out.
All right, thank you, doctor. The second question reads, how do you incorporate genomic and molecular testing into the diagnostic algorithm for hematologic cancers?
Yes, so as you probably got a snippet of, we live right now in the genomic era in hematologic malignancies. So the reality is every lymphoma, every case of a plasma cell dyscrasia, every case of an MPN, MDS, AML, right now comes subclassified on the basis of this. And I didn't talk today because it's a very broad topic, but the classic example is acute myeloid leukemia. And in acute myeloid leukemia, pretty much you actually don't really have a diagnosis until you have the molecular information in AML. I think for general practitioners, that classification of acute myeloid leukemia is maybe a little bit less interesting, but I think it's important to remember that right now, when we're taking care of patients with AML, and this is just a practical example, right now a patient gets hospitalized, we can make the diagnosis of AML very quickly, right? When we look at the blood, we're suspicious, and the flow cytometry will define AML, so we can have that diagnosis within hours. But right now, for the majority of patients, we are waiting days to have the information of the molecular testing the genetic information to start the patient on therapy. So for example, these are like two examples in the context of AML. There's a gene called FLT3, FMLS like tyrosine 3, and FLT3 ITDs, internal tandem duplications, are essential for us to know at diagnosis, and we start patients on therapy against FLT3 with drugs such as gilteritinib, within a few days, once we know the status. Another example in this context is that, for example, patients who have p53 mutations in the context of AML. So acute myeloid leukemia is a disease where younger patients are still receiving this anthracycline-based therapy. You probably heard of it. It's a regimen called 7+3. We've used it for a long time. It includes idarubicin and cytarabine. But depending on the series, 10 to up to 15% of patients, probably somewhere between 8 and 12% of patients, have p53 mutation. 7+3 based regimen should not be used in patients with p53 mutations. So the reality is every patient, when they come through the door with AML, we need to know their genomic features in order to customize treatment. So not only is it, this talk is about evaluation and diagnosis, and the question was, how does this become part of the diagnostic algorithm? But the point being that we need to know this in order to treat patients effectively. And I'll give you one other example that's important. And, p53, we as malignant hematologists, I think to our detriment, paid not enough attention to p53 up until the last 10 years. But there's another type of lymphoma that's fairly common. It's called mantle cell lymphoma. That lymphoma has historically been treated with alkylating agents. So mantle cell lymphoma has been treated many times with regimens such as R-CHOP, alternating with a regimen called DHAP, or where we use a cytarabine-based regimen for it. Today, we know that, or we use something called bendamustine and Rituxan, bendamustine being this alkylator purine analog. It is contraindicated to give those type of regimens to patients with mantle cell lymphoma that have p53 mutations. So this just highlights the importance of molecular testing, not just for the diagnostic algorithm, not just to think about prognostic biomarkers, but to think about predictive biomarkers, to customize therapy for personalized therapy for these patients. So a critical question. Thank you.
All right, thank you, Professor. The third question reads, how do you assess for treatment-related myeloid neoplasms in a patient with a history of prior cytotoxic therapy or radiation exposure?
Yeah, so a very important question. And so we typically assess, the key part is obviously, the key part in this is the history of the prior therapy that they've received and the time frame between one and another. We are faced right now, maybe because our diagnostics have improved, with a lot of patients that are diagnosed with 2 malignancies at the same time or in short sequence, weeks or months after the diagnosis. So typically we think that treatment-related myeloid neoplasms occur years after therapy for another cancer with chemotherapy or radiation therapy. And there are very classic genetic abnormalities. And one is mixed lineage leukemia, MLL gene rearrangements in the context of prior therapy. So it's that integration that helps us kind of understand it.
All right. Okay. Thank you, Professor. The fourth question reads, in a patient with relapsed or refractory Hodgkins lymphoma, what salvage chemotherapy regimens do you consider, and what role do novel targeted agents, such as the ones listed here, play in the management?
Yeah, critical question. So the reality is, obviously, like every aspect of medicine in any field, it's rapidly evolving. So let me start by the second part of the novel targeted agents, because we are incorporating these agents up front. So it's listed here: brentuximab, vedotin, and checkpoint inhibitors. And basically, we are now, for stage 3-4 disease, we are using both these agents. So there was the Echelon trial, which combined brentuximab vedotin with patients with stage 3-4 disease with AVD. I told you briefly about this ABVD regimen. And then there's been the SWOG intergroup randomized trial that has looked at nivolumab in combination with AVD versus brentuximab in combination with AVD. Exciting data that has emerged over the last year has shown that for patients with stage 3-4 disease, nivolumab AVD is superior to brentuximab AVD. And brentuximab AVD was already superior to to ABVD. So obviously using these agents depends on whether we had used them frontline or not. The cornerstone of the management of relapse refractory disease is the use of brentuximab and PD-1 inhibitors, but as long as they haven't been used before. And so in the modern era, we used to always try to take these patients to an autologous stem cell transplant. But in the modern era, this is a bit unclear. When you look at the data, even with the management of the combination of nivolumab and brentuximab in combination in the second line, the reality is we might be curing almost everybody. So the jury's still out how to best use this.
All right, thank you, Professor. The fifth question reads, when would you consider autologous or allogeneic hematopoietic stem cell transplantation in the treatment of Hodgkins lymphoma, and what are the key factors that guide this decision?
Yeah, so a very important question. So the standard has been, so I'm gonna bear with me. I'm gonna answer it in several ways, but let me tell you what the standard has been historically. The standard has been that if you have relapsed Hodgkin lymphoma, you should go through an intense salvage regimen. Something like ICE or DHAP. This is ICE is ifosfamide carboetoposide, and DHAP includes platinum and cytarabine, and collect the stem cells and take the patient to autologous transplant. That's been the standard in the field. We've known for a long time from registry data and retrospective data that some patients with, by the way, with autologous transplant, patients are cured. And we've known for a long time from registry data that patients who undergo allogeneic stem cell transplant can also be cured of their Hodgkin's lymphoma. And, as I mentioned before, with the novel agents, especially the PD-1 inhibitors, we might be curing almost everyone with Hodgkin. So this might be less of an issue in the future. But I'll just tell you briefly that, about 10 years ago, a young patient of mine, a 32-year-old patient, he failed an autologous stem cell transplant. And, I was contemplating taking him to allogeneic stem cell transplant. And at the time, I asked Professor Engert at the University of Cologne, I sent him a message, and I said, Professor Engert, by the way, this group, Volker and Engert, the German Hodgkin study group, which they've led, are pioneers and the leaders in the field. And I said, Dr. Engert, this was before the era of PD-1 inhibitors. I said, how do you feel about taking this patient to an allogeneic transplant? And Dr. Engert said, allogeneic transplant can only be seen as an experimental procedure. I think we lack data to support the use of allogeneic transplant, and I would advise against it. Anyways, Dr. Engert being a giant in the field, obviously one thinks about it a lot, but I ultimately took him to allogeneic transplant. He's being cured of his disease, and he's done well now for over, I think, 11 or 12 years. So the problem is that we don't really know when to take patients to these type of procedures. But what we do know is that you have to be pretty fit to go into an allogeneic transplant. And, you have to counsel patients very carefully about this. The patients who you'd contemplate taking them to an allogeneic transplant, with somebody else's cells, the reality is allogeneic transplant still today has a pretty substantial peri-transplant mortality. So in the modern era, still today, it's estimated that somewhere between 20 and 30% of patients will die from peri-transplant complications. And so that's sobering for this type of population, right? That 1 in 3 patients will ultimately succumb or have severe problems with chronic graft versus host disease, right? Which is the other issue that we face in the field. So it's difficult. I have to say, I haven't taken a patient to allogeneic transplant now. It's probably been about 10 years because patients have fared well from that perspective.
All right. Thank you very much, Professor, for that answer. The sixth question says, what unique late effects like secondary malignancies, cardiovascular disease, infertility, do you monitor for in long-term survivors of Hodgkins lymphoma? And how do you incorporate screening and preventative strategies into their care?
Yeah, another critical question. So obviously, so the reality is, in a nutshell, all long-term monitoring of patients with hematologic malignancies, the cornerstone is history, physical exam, blood work. And so whether it be Hodgkin's, whether it be patients who've received an allogeneic stem cell transplant, that is the cornerstone. And I think it's important because there's also a push, there's not enough oncologists, there's not enough hematologists in the world. And, a lot of this is being, I'm personally a bit against this, but there's a push throughout the world to say, well, you're going to be monitored by your primary care physician. And rightfully so, primary care physicians who maybe don't see a lot of long-term survivors of Hodgkin's, they're nervous about this. And they're thinking about, well, what are the sophisticated diagnostic tests that we have to order? And I mean, we're going to talk about that, but basically the cornerstone is still, as I mentioned, history, physical exam, labs. In the context of Hodgkin's, one of the key things is obviously thinking about the number of years from when they were treated and whether or not they received mediastinal radiation. All that data about the horrendous cardiovascular morbidity and mortality, most of it comes from the use of mediastinal radiation, and also the breast cancer risk to a great degree. So in the modern era, we're trying to avoid mediastinal radiation as much as possible, but we typically say 8 to 10 years out is the time to start carefully monitoring patients. And so typically they're referred to cardiologists. They have surveillance echocardiograms. The evaluation includes evaluation for global strain. And then in women, this is also very important to kind of think about the risk of breast cancer. And, remember, the majority of these women are young women. So the majority of these women have dense breasts. Mammograms alone are insufficient to be used as a screening at this 8-year mark. So they frequently alternate mammograms and MRIs of the breast. And then the problem of infertility remains a tremendous problem. And so patients are typically counseled before they start on therapy about this. And women, there's many options in the modern era for these women. Infertility is a bigger issue in women than men, but a very basic one is, although not fully proven, is inducing menopause during treatment. So patients typically get LHRH agonists during therapy. But those are absolutely essential. I mean, for the care of patients with Hodgkin's, all hematologic malignancies, it requires a multidisciplinary approach. So you need reproductive endocrinologists, special fertility specialists, especially to counsel women. You need cardiologists with expertise in this. So that's why we're using, for example, most centers, and I'm sure you have it at your own centers, have now oncocardiologists, who are these cardiologists that specialize in the cardiac effects of cancer, the toxicity of cancer treatment, and the long-term sequelae of having had cancer and its treatment on this.
Okay, thank you very much, Professor. The last question here says, how do you incorporate interim PET or CT imaging during Hodgkin's lymphoma treatment to assess response and potentially modify the planned therapy based on the findings?
Yes. So right now in the in June of 2024, the standard approach to PET CTs in the context of Hodgkin's is to perform a PET CT at diagnosis for staging purposes and to serve as a baseline. So the idea is shortly before starting treatment to get a PET CT, then to get an interim PET CT. So typically, if patients are getting 6 cycles of chemotherapy, typically in that context, it's after 3 cycles. And then at the completion of therapy, 6 to 8 weeks out to undergo another PET CT. And if that PET CT, if the interim one showed the patient had achieved a complete metabolic response, and that complete metabolic response was maintained at the end of treatment PET CT, to not receive any additional PET CTs. And I mentioned before, for example, in the United States, the guidelines is, shared decision-making afterward. And most oncologists and hematologists are repeating CAT scans of the chest, abdomen, and pelvis every 6 months for 2 years post-therapy. So that's the year 2024. And that's for, patients who are getting 6 cycles of chemotherapy without radiation. But in the context of shorter courses of chemotherapy with consolidative radiation, you typically do the PET CT after the chemo to make sure they're having an appropriate response and then moving into the radiation. The reality is, although we don't have full information, that the studies done with immune checkpoint inhibitors, and I mentioned nivolumab, that those patients, the rate of false positive results for PET CTs are very, very high. And so the SWOG trial showed the highest numbers we've ever seen, the highest proportion of patients we've ever seen with false positive PET CTs. And the thought is that this is in part due to the activation of the T cells and the activation of the non-cancer immune cells in the microenvironment. So it might be that we're facing a lot of false positive results. We're facing higher cure rates than we've ever had. So the jury's still out how we're going to do PET CTs. We still do it in the way I described, but I wouldn't be surprised in the future of 2 kind of fundamental changes. One is that we might opt to not have interim PET CTs, or even if they remain positive, to kind of continue therapy. And the end of treatment PET CTs, we might push them out even further out. So instead of the 6 to 8 week mark, we might push them out to 12 to 16 weeks out. An important issue in especially lymphoid malignancies that we've never been able to show that early diagnosis of relapse changes outcomes. So that's the other.
Okay, thank you very much, Professor. So 2 more questions popped up while you were addressing the rest. So the 8th question reads, is cure and lifelong survival possible in patients with lymphoma?
Yeah, so the answer is the typical dogma is that the classic dogma has been that aggressive lymphomas can be lethal quickly in weeks to months, but that aggressive lymphomas such as diffuse large B-cell lymphoma and Burkitt lymphoma are curable with chemotherapy. Now, we've known, for over 30 years that all lymphomas are curable with allogeneic stem cell transplant. But I talked about some of the challenges with allogeneic stem cell transplant. And so they're typically not used in the context of lymphomas. It's been said that with chemotherapy, indolent lymphomas, diseases such as CLL, chronic lymphocytic leukemia, or mantle cell lymphoma, those diseases are not curable with chemotherapy, and that is true. But right now in the modern era with CAR T, some of these patients might be cured with CAR T. So this is in flux, and the bottom line is that cure and lifelong survival are not only possible, they are now, interestingly enough, in the majority of B-cell lymphomas, they are a reality. It's a very exciting time. So cure and lifelong survival will hopefully become the standard for patients with lymphoma.
Thank you very much, Professor. The last question reads, what is the role of exon 12 mutational analysis in myeloproliferative neoplasms, especially Polycythemia Vera?
Yeah, so this is a cornerstone in the diagnosis. And as we talked about, the majority of patients with Polycythemia Vera and essential thrombocytosis have exon 12, have JAK2 mutations. And, the classic one is that valine to phenylalanine mutation. So it is the role of exon 12 mutations is that patients need to be tested for it in that sense. And what all the participants, I mean, obviously this talk is mainly geared to non-hematologists, but for the non-hematologist group, the non-oncologist group, the point is in myeloproliferative neoplasms, what you need to be aware of is that the majority of these patients, almost all patients, are going to have either a JAK2 V617F mutation, a calreticulin mutation, a MPL mutation, or in the context of CML, chronic myeloid leukemia, they're going to have a BCR-ABL translocation. If you're familiar with all those 4 to 5, you basically have covered what will be diagnostic for the vast majority of myeloproliferative neoplasms.
Thank you very much, Professor. Thank you for addressing all the questions in a comprehensive manner. So having said that, we'll directly proceed to the Q&A, to the post-CME quiz session. So we'll share the link down below in the chat box. Attendees will have 10 minutes to attempt the quiz. After that, we'll recuperate and we'll attempt the quizzes together.
Okay, so let's quickly go through the questions on the quiz and then we'll finalize the session. So the first question reads, in which of the following hematological malignancies can peripheral blood flow cytometry be diagnostic? A, chronic myeloid leukemia, B, diffuse large B-cell lymphoma, C, chronic lymphocytic leukemia, and E, essential thrombocytosis. Professor Ubaldo.
Yes, so I think we spoke during the session about the importance of flow cytometry, but that many times it's non-diagnostic. And one of the few diseases where the blood is peripheral blood flow cytometry is diagnostic is CLL, which the majority of participants responded correctly. And that's because these B cells have a particular phenotype. So classically, it's B cells with CD20 expression that also co-express CD5 and CD23.
Thank you very much, Professor. So the second question reads, what is the most common cause of cytopenias in patients over the age of 65? Aplastic anemia, myelofibrosis, myelodysplastic syndrome, and paroxysmal nocturnal hemoglobinuria. So, Professor, take the stage.
Yes. So we spoke during the session about the fact that one of the cardinal features of myelodysplastic syndromes is ineffective erythropoiesis, ineffective hematopoiesis and kind of ineffective production of blood cells in the peripheral blood. So they have a packed marrow many times, but in the periphery, they have cytopenias. So that's the point. And that's what distinguishes this from myeloproliferative neoplasms, right? MDS, the count in one or more lineages tend to be low. The myeloproliferative neoplasms have elevated cells. So chronic myeloid leukemia, typically elevated white cells. Polycythemia vera, typically elevated red cells. Essential thrombocytosis, elevated platelets. It's not that they have to be unilineage, but that's the point.
Okay. Thank you, Professor. So the third question reads, if a patient with a history of Hodgkins lymphoma and mediastinal radiation develops dyspnea 10 years post-treatment, what is the least common cause? Recurrence of Hodgkins lymphoma, constrictive pericarditis, coronary artery disease, and aortic stenosis.
Yeah, perfect. So the majority of respondents had the correct answer. And so the point being is thinking about pretest probability, and kind of the educational objectives were just to highlight that although you can never say that Hodgkin's will not relapse, many years out, you have a higher risk of complications from therapy than risk of recurrence of the lymphoma. And so we talked about these problems like a secondary malignancy or the heart issues, and especially the cardiac issues related to mediastinal radiation are very important. So the problem of accelerated coronary artery disease, aortic stenosis, valvular dysfunction, and constrictive pericarditis. So, and less common recurrence of the Hodgkin's.
Okay, thank you, Professor. The last question we have is, what is the most common lineage of lymphoma cells? B cell lineage, T cell lineage, NK cell lineage, and undefined.
Perfect. So the reason for this question was just to highlight, we talked today about how CLL and diffuse large B-cell lymphoma are the most common lymphoid malignancies, and they're both malignancies of B cells, and then follicular lymphoma and marginal zone lymphoma. And the real reason to talk about it is that all of us as clinicians, we are going to be reviewing with our colleagues, the pathologists, some of the results of the biopsies or the flow cytometry. And that they're going to be talking about things like CD20 expression as a marker of B cells versus CD3, which is a marker of T cells, CD8, cytotoxic T cells, CD4. So thinking about pretest probability, when you're suspicious that somebody has a lymphoid neoplasm, you usually expect to see these B cell markers. And so you should be thinking about it that way. Thank you.
All right. Thank you very much, Professor. I will leave the stage to my colleague, Dr. Tadel.
Thank you very much, Dr. Simon. And once again, thank you very much, Professor. So on behalf of Yetenaweg and the entire medical community here, I would like to extend our sincere gratitude for your insightful and informative guest lecture. So your willingness to share your knowledge and insight has been invaluable in advancing our understanding of hematologic malignancies. So thank you again for taking the time to be with us. We're very grateful for your contribution and look forward to any future opportunities to collaborate. And thank you to everyone that has attended this webinar. Once again, thank you very much, Professor.
Thank you. Have a good rest of your weekend.
Thank you and good night.